Okay, so welcome to my stream. We have very little time, and therefore let me just do it as fast as possible. So yeah, first topic we have is peritonitis. So peritonitis is the inflammation of the peritoneum, as we know. So it is the inflammation of the peritoneum. Okay, peritonitis, inflammation of the peritoneum. They can be classified into primary or secondary. Primary is serious spontaneous peritonitis of childhood, spontaneous peritonitis of adulthood, tubercular peritonitis, peritonitis associated with dialysis. Secondary is peritonitis from intra-abdominal source, most commonly it is the most common form of peritonitis. So you have perforation of a hollow viscous, perforated duodenal ulcer, gastric ulcer, enteric ulcer, tubercular ulcer, perforated mucus, diverticulum, perforated colonic ulcer. Direct spread, you have post-inflammatory acute cholecystitis, gangrenous acute appendicitis, gangrene of the intestine, and acute necrotizing pancreatitis. Then penetrating injuries to the abdomen where the organism gain entry from the outside. Then you have postoperative peritonitis, which is due to introduction of the infection during surgery, which may be due to postoperative leaks, foreign body mob in the abdomen. Then you have peritoneum paturation peritonitis referred after pregnancy and delivery, and blend injuries to the abdomen, which can be spilled into a peritoneal cavity. Example, bile and blood and bile can travel along the paracolligator and manifest as pain in the right iliac fossa, causing guarding and rigidity. This has been known as Valentino syndrome. So pathogenesis due to any of the causing following mentioned above. Infection sites in the causative organism multiply in the peritoneal cavity. Gram-negative organism, we have gram-negative organism, enterocoli, bacterioids, bacteria from outside of the alimentary canal, and these organisms generally proliferate in the cavity, resulting in peritonitis. As a result of this, there is secretion of large amount of fluid into the peritoneal cavity, leading to third space loss, which leads to severe hypovolemic shock. This fluid is rich in proteins and toxins due to powerful endotoxin disease by gram-negative bacteria. Toxic shock syndrome ensues. Then fluid is rich in fibrinogen. Which forms fibrin and inhibits localization of infection. Then peritoneum loses its shiny surface, becomes reddish and odomentous, and it's covered with thick fibromatous exudative. Omentum is a fatty apron which is with rich blood supply. A mobilized double layer peritoneal fold acts as a policeman to seal the area of infection or perforation. Examples are perforated duodenal ulcer, acute appendicitis, acute diverticulitis, etc. It also serves to supply the collateral blood supply to the ischemic viscera. It also has immunological functions such as supply of phagocytosis to destroy unobsonnated bacteria. So, organ-specific organisms, you have bacterial perforation, sterile with a minimum gram-positive organisms, ileal perforation, appendicitis, appendicectomy. Organ-specific organisms, so gastric perforations, sterile, minimum gram-positive organism, ileal and appendicitis is anaerobic organism in 30%, aerobic in 30%, anaerobic in 10% patients. Then gastric perforation, aerobic, minimum gram-positive bacteria. Colonic rectum is fecal swellage for a load of 10 to the power of 12 or more gram-negative and anaerobic bacteria. So again here, gram-negative bacteria, small intestinal and combination. Enterocoli, Streptococcus faecalis needs bile to grow. Present in UTI, general tract, and also in intestines. Aerobic and anaerobic streptococci are the most common, and organisms producing peritonitis. Bacterioids, they are anaerobic organisms present mainly in the lower intestine. Then outside is pneumococcal or tuberculosis. Then you have common causes of perforation: perforated duodenal ulcer, gastric ulcer, appendicitis, enteric ulcers, tubercular ulcer, gangrene intestine, perforated carcinoma of the left colon. And uncommon causes of peritonitis, you have perforated gallbladder, ruptured amoebic liver abscess, necrotizing pancreatitis, perforated mucus, diverticulum, sigmoid perforation. Then perforation of post-inflammatory and perforation post-inflammatory and post-operative. It can be multiple sources of E. coli, enterocoli, bacterioids, endotoxins, septic shock, which leads to multi-organ failure and renal failure. Finally, so again endotoxins, then peritoneal irritation leads to exudate collection in the third space loss, hypovolemic shock and renal failure, finally multi-organ failure and death. Fibrin plaques, early case of peritonitis with fibrin plaques all over the peritoneal cavity. So these are the pathogenesis. Peritonitis, discharge, capillary leak, discharge of the histamine and other vasoactive substances lead to protein fibrinogen-rich fluid into the extracellular fluid. Fibrinogen fluid helps in destruction of the bacteria. Tissue thermoplastin released from the mesothelial cell converts fibrinogen to fibrin, thus forming fibrous adhesions. So tissue edema will be seen, paradoxically intravascular hypovolemia will be there, hypertension, finally third space sequestration causes of peritonitis. So third space interstitial fluid, third space, and cell. So this is the third space fluid superposition. Then types of peritonitis: you have local peritonitis and generalized peritonitis. Local is perforation is small and sealed off immediately by the omentum. And generalized peritonitis, if the contents leaked into the peritoneal fluid with force as a percent. Interstitial perforation or due to filling organ, example Meckel's diverticulum perforation. So it gives rise to local peritonitis, small gastric ulcer, diverticular perforation, gallbladder perforation. Anatomical factors also play a role in local peritonitis. Example: retrocecal appendicitis with perforation. It is behind the cecum and retroperitoneum. Signs are confined to the right iliac fossa only. In posterior gastric perforation, acute signs are limited to the upper abdomen. And anatomical factors play a role in the local peritonitis. So signs are confined to right iliac fossa. Some posterior gastric perforation acute signs are limited to upper abdomen. Pelvic peritonitis is another example. It occurs following septic abortion or esophageal perforatis. Virulence of the bacteria is more in chronic perforation with generalized peritonitis. Duodenal ulcer perforation can manifest as severe pain in the right iliac fossa mimicking appendicitis. Reason being a broad spectrum paracardial contents travel down to the right iliac fossa, thus Peritoneum syndrome. So again, duodenal ulcer perforation can manifest as severe pain in the right iliac mimicking appendicitis. It is because from the appendix it will come down to the via the right paracolic cutter, travel down into the right iliac fossa, and is referred to as Valentino syndrome. Valentino appendix. Referred of Valentino, who lived in this time. He was diagnosed with appendicitis. He underwent appendicectomy, continued to have peritonitis. Therefore, continued to appendicectomy, continued to have peritonitis, developed pleural effusion and sepsis. It is also called Valentino syndrome because in the inflammation in the upper abdomen, viscera contents can travel down into the paracolic gutter and resulting in pain and tetanus, mimicking appendicitis. So, factors deciding the severity of peritonitis: clean perforation, sterile for 6 to 8 hours. Hence, if you do it early, then it will be mild and chemical peritonitis. Early treatment is good result. Then distal gut perforation and bile peritonitis, very dangerous and severe, causing sepsis, septic shock early. Then you have postoperative peritonitis, usually occurs with an anastomotic leak, perforation sealed off early by omentum causes mild peritonitis. Retrocecal appendicitis produces minimal local peritonitis. On the other hand, perforated Meckel's diverticulitis produces diffuse peritonitis. So, and few causes are given: factors affecting a speed of peritoneal contamination, then stimulation by purgatives, virulence of organisms, perforation, closed loop of obstruction, immunocompression status, zinc status. And clinical features. So clinical features is it depends whether on localized peritonitis or generalized. In case of retrocecal appendicitis, signs may be minimum, but guarding and rigidity will be is characteristic. So features of generalized peritonitis are as follows. Because few causes: Meckel's diverticulum, tuberculosis, transverse colon injury, early ventricular perforation, pancreatic necrosis, and chronic duodenal ulcer perforation resulting in biliary peritonitis. Postoperative peritonitis due to a mop left hand following cesarean section, fibrous band causing gangrene of the tummy and layers, and sigmoid diverticular perforation causing peritonitis, fecal peritonitis causing and fecal fistula, proximal jejunal transection, and colostomy jejunum, retractor colostomy, neurosection specimen, acute pancreatitis, and mesenteric ischemia giving rise to gangrene. Finally, massive gangrene following superior mesenteric arterial occlusion. Patient had severe acidosis. Then severe abdominal pain, which is cutting in nature, becomes source of movement of abdominal walls, hence the patient lies in the bed. Persistent vomiting due to irritation of the parietal peritoneum. Pulse rate is increased. Increase in the pulse rate may be early indication of peritonitis in case of gangrene of the bowel or peritonitis following perforation of the bowel. High grade fever with chills and tremors indicating a septic again severe abdominal pain, persistent cutting in nature. Motion movement of the abdomen. Increased blood flow. Lesion of peritonitis in case of suffering high grade fever with chills and tremors. Cough tenderness. Rebound tenderness from boxing. Rigidity of the arm. Messages, epicrotic faces. Epicrotic faces is hollow, bright eyes, pale and pinched face, and cold perspiration in head and brows, and dry legs and tract tongue. Complete CBC, so account of the predominant neutrophil count, but is sugar is done to diabetes X-ray and total count. Report analysis and diagnostic sign of peritonitis and epicrotic faces is synchronized round in cheeks or dehydrated blood in raised tube. Less appearances is more than less appearance to accumulation of fluid. Here in the bowel wall, gangrene, obliteration of source of happening. Run ultrasound to detect fluid in the abdomen. Following our frank persist peritonitis more than 24 years old. Chest X-ray, gas under the diaphragm. Natriuretic catheter showing gas in the peritoneum. Then diaphragm is elevated. Fundicular bowel is in the post-traumatic diaphragmatic hernia. Subphrenic abscess, both mild pleural effusion on both sides. Gas in the bowel wall. You have indicates gangrene of the bowel. While green fluid duodenum ulcer, gallbladder perforation. Flagellant is green, thickened passpirate with fluid oras. Paralytically acid up. All of these others, hemorrhagic may be hemorrhagic pancreatitis. Food particle is hollow viscous perforation. Serous exudative is early pancreatitis and tuberculous peritonitis. Ultrasound has many advantages, though it may be. It cannot point to a specific site. Tenderness, fluid, and all you can see. Abdominal tap, aspiration of the blood indicated in abdominal aspiration of blood indicated in hemoperitoneum or gangrene of the bowel. Biliary peritonitis perforation of the bowel. Frank pus is gram-negative bacteria. Full pus is due to anaerobic bacteria producing free fatty acid and then esters. So abdominal tap and hemoperitoneum blood. Aspiration of biliary peritonitis. Frank pus is peritonitis due to gram-negative bacteria. Foul smelling is anaerobic. Amylase esterases for pancreatitis. CT enhanced scan. Hollow viscous perforation and ischemic cholangitis and diagnostic laparoscopy suspect cases of peritonitis. Treatment is aspiration, GIT RIS tube. Charts you have to do. This will Peritoneum is followed by peritoneal diatomaceous. Second or third encephalosporins should not have serious toxicity because restore volume, restore oxygenation, restore perfusion, dopamine and all. Restore normality by war against sepsis. Antibiotics in surgical sepsis. Principal sensation should be made, culture and sensitivity should be done, sepsis should be done, removal of appendix and whatever is removed is should do. Inside establish diagnosis, explore pus culture sensitivity, treat the cause, peritoneal drainage and closure. No present with peritoneal implementing laparotomy, closure of perforation, feeding the ostomy with done. Placed stomach first after first day. Tension such as have been provided with closure of the peritoneum can be done. Used in diffuse peritonitis to do as abnormal cassettes may as a process for the patient. Laparotomy is leaving it open without approximation of the anterior abdominal wall. Yeah, open, which is abdominal fissure, peritoneum now suture. Compartment syndrome implanted. Significant fluid loss and severe infection is there. Closed is using legs measure, probably less or even zip to protect the exposed viscera. Can minimize infection, however, abdominal compartment syndrome and perforation in the bowel can occur. Indication of laparotomy is second look procedure is contemplated and non-operative you can do all this. Shield perforations through sick patient to let the surgical procedure local respirators may result with treatment. And that's it for peritonitis. My voice is kind of gone, so it is done.